So my talk is on lobar or sublobar resection for peripheral stage 1A non-small cell lung cancer. This is just an image. It's very sketchy here because that's how it was in the beginning. We didn't know exactly what it was. Just to touch about history, pneumonectomy was the treatment of choice till 50s because of the first long-term survival seen by Graham and all in pneumonectomy for gynecologists who survived for almost 30 years. And we have to know also there was a time when stapling came into use by 50s in Russia and by 60s in the US. And again, there was seeing a review of all the cases of pneumonectomy. They did not find any very significant improvement in terms of survival, and what was almost twice with not improvement in any survival. So, lobectomy became the standard of choice from that period onwards. And yeah, so the interest in sublobar was always there from the beginning because of the case we see. They are all basically old patients with COPD, they don't tolerate lobectomy, forget about pneumonectomy. So this was always an interest. So in 73, Jenskin reported about the survival in early cases of lung cancer, where he saw a 56% 5-year survival. So CT scan again, we have to see it came in the late 70s. The LC lung cancer study group we know about was based on chest X-ray, and they used the CT scan just to look for metastasis only. So this was published by Ginsberg et al. In 95, and that changed the course where it became like lobectomy was the standard of care because we had a regional recurrence rate which was almost 3-folds in the sublobar group and a 5-year survival of 73% in the lobectomy group. Then, so this was basically 95 till 2022 when we had trials coming, the JCOP, and by 23 we had CALGB come. We have to understand that obviously lobectomy is easier to perform because of anatomy plane, the staplings had come by the time, energy devices are there, and the cells improved. It was more reproducible. So sublobar, the RCT, we got 2 randomized control trials, one with about 1,000 patients, Japanese group published in 2022, and the North American group with about 697 patients in 2023. So coming to JCOP, basically this was again for small size peripheral lesions, less than 2 centimeters. They did not include middle lobe tumors in this case. So they randomized to both lobectomy and the segmentectomy arm. And the primary endpoint was OS, and secondary endpoints were basically post-op FEV1, and at 6 months and 1 year, relapse-free survival, proportion of local recurrence, and worst events. So if you look into it, the overall survival was definitely much better, 91.1% versus 94.3%. And if you look at the post-op respiratory function, that's 1 year, it was just 3%. They did not achieve the proposed criteria of 10%. And if you see the relapse-free survival, it was almost similar, 87.9 and 88%. And recurrence pattern, if you see, there were more local regional recurrence in the segmentectomy arm, which was almost 2-folds, and compared to the lobectomy arm. And if you see the cause of that, this is very interesting because for lung cancer deaths, it was similar, but for other cause of secondary lung cancers and other carcinoma caused like respiratory and cerebrovascular disease, it was higher in the lobectomy arm, which basically tilted the survival, the result in this study. And so they concluded that JCOP is the first phase 3 trial to demonstrate the benefits of segmentectomy with significant difference in overall survival. These results indicate that segmentectomy should be the standard of care for lobectomy with patients with small size, less than 2 centimeter, tumor to constant ratio of more than 5. Next, if we see analysis of the JCOP, people say it's like a 3% study because they have got 3% better survival in this group, 3% better lung function, and 3% more local recurrence in sublobar group, and 3% more cancer deaths in the lobectomy arm. And next comes the CALGB, it's a North American trial across the Atlantic, and this is basically from Nasser Al-Turki group. So this is a multi-center again, and they confirm these are again patients with early stage T1A and 0 with tumor size less than 2 centimeter, 2 arms, lobectomy and sublobar. In the sublobar arm, they have the options of doing both a segmentectomy as well as a wide wedge. Primary endpoint was disease-free survival, secondary was OS, PFT at 6 months, and rates of local regions. Oh, something wrong. I think you can switch the timer off on this time. Yeah, the CALGB. So you can see that in this they have the liberty of doing in the sublobar either a segmentectomy or a wide wedge. They include even middle lobes also.
the extra time.
Yes. So if yes. So this is the DFS and OS. If you see in both the arms, there is lobectomy arm, segmentectomy arm, and there's a wedge. They were quite similar, so it was found to be non-inferior. And if you see the disease recurrence, they were numerically higher on the sublobar group and not very significant. And if you see in terms of pulmonary function test, there was an absolute difference of just about 2% in terms of FEV1 and FVC at 6 months. So they also concluded that the KGB DFS and OS was not inferior for sublobar versus lobectomy. 5 years DFS of 63.6 versus 64.1, and 5 years OS of 80.3 versus 78.9. So if you look at comparing these two, push a little to side. You can see here that in the DFS and OS, in both were non-inferior. And in fact, if you see the Jacob trial, it was found to be superior in terms of the overall survival. It was found to be superior, and in terms of adverse events, it was basically on lower on both sides, but we had a single agent in the Japanese group. It was in 2 digits in the North American study. They had a difference of about 3% in the local regional recurrence. And so I'd like to say, which is the best of times are we, because 2 trials have had the same conclusion in highly selected patients. The sublobar was non-inferior, in fact superior in lower in the Japanese trial. But if you see by statistics, the survival in stage 1A and 1A2 are 90% at 5 years and 85% at 1B. So if you see again the Jacob has performed very well, not very well, I mean 88.0%, 87.9%, well below the mark, and yeah, so Jacob has basically performed very well at 87.8, whereas the KGB, if you see the 5 years DFS, it's 63.6, 64.1. I can't see this maybe. That hand is also there. Yes. See, if you see the 5 years OS in KGB, it's 80 and 78%, but in Jacob, it's basically about 90, 91 and 94. There's a striking difference. And if you see in terms of the nodal evaluation, the KGB basically allowed for level 10 and 2 less than or equal to 2 and 2 station to be sampled, whereas Jacob was basically following as mediastinal window dissection. As per the ILC recommendation, it allowed for R0 uncertain resection in the KGB group, and Jacob followed the criteria of ISOC completeness of resection. So I think we are in the worst of times also now, because there is a striking difference in the outcome. A trial comparing the same set of population, if they had surgery in Japan, they had more chance of surviving compared to those in the North American group for similar disease. So in summary, I would say that Japanese study is a wonderful trial which has come out in those times with a 5-year-old survival superior in fact. That's basically because of the increased mortality in the second lung cancer and other respiratory and cardiac complications. KGB comparative is in overall survival comparative poor survivors to survival statistics and inferior to Jacob. And in summary, I would say that lobectomy with natural boundary will continue to be the standard of care in majority of the case because it's most easily reproducible, and we take into account the stats, which we always ignore most of the time. Just for a 3% kind of sparing effect, I mean, we can ignore segmentectomy in cases. And so this is, to conclude, I would say there's a convincing evidence for segmentectomy as per the Jacob, and screen-detected early lung cancers are the one going to benefit most from this. And there's clear indication now for a segmentectomy and lobectomy and an immunectomy, which will not be discarded. And obviously, to achieve this, low-dose CT screening in high-risk patients is the way forward if we are to achieve more and more segmentation. Thank you.